Let's talk about the conceptual framework and the process of a consult, and then discuss how to be an excellent liaison. The point of a consult is to utilize the expertise of another physician or team that is outside of the primary team's scope of practice or knowledge. The patient often sits in the primary team's scope of practice or knowledge base, but sometimes they lie between the areas, and sometimes they are more purely the consultant's patient, which warrants transfer. The interesting thing is that traditionally, the consult usually comes in the form of a statement, but the consultant would prefer this to be a question. We can talk about why this is a bit later, but I want to start by getting you to think about where each patient lies on this diagram as you conduct consults. Let's move on to introducing the consult process. Now let's go through a conceptual framework of the consult to understand the basis for some of the practices and processes. I've broken down the process into 4 components: the 2 teams, primary and consultant, and the 2 activities, communication between the teams and the patient interaction. Of course, there are way more variations on possible dynamics, but I wanted to simplify it to relay the most essential components and the concepts. Now, I'm not here to make fun of the primary team or the consultants. I don't mean any of this in a derogatory sense, but I've translated some of the conversations into the bare bones to relay the process instead of the content. It's hard to turn a clinical observation into a question, especially when you don't have the vocabulary for it. Again, this is essentially the basis for needing a consult, so expecting a clear-cut question is often unfair in many circumstances, and the reason that there is a live dialogue in the first place, instead of written consult request. To simplify, the primary team sees something in a patient that is different than what they're used to seeing and requests help. So the primary team calls the appropriate consulting team, but not always, and a short discussion takes place. The problem is that there are often barriers in this process that we will discuss later. Hopefully by the end, there is some clarity as to what the expectations are on either side, often referred to as the consult question. When the consultant has a question to answer, it sets the consultant up to be more successful by setting realistic expectations. When the primary team gets off the phone, they should have a clear idea in their mind of the question the consultant is going to answer. The question is more for the primary team to help set realistic expectations. Let me illustrate with an example. Let's say neurology calls psychiatry and says, "I have a consult. We have a patient with visual hallucinations." Now, if psychiatry accepts this at face value without clarifying the consult further, they're setting themselves up for failure. Psychiatry could go and see the patient and confirm, "Yes, these are visual hallucinations," and call neuro back saying, "You're right." Psychiatry could also call back and say, "We think these visual hallucinations are due to a brain tumor," but that wouldn't even be psychiatry's call. Neuro could make that call themselves. Psychiatry could simply rule out primary psychiatric etiology, call them back and say, "This really isn't our problem or in our realm." Or psychiatry could come up with a treatment plan. Any of these might be reasonable approaches, but you don't know until you ask and you have that discussion of the expectations and what the primary team wants from you. So ultimately, I personally don't find the question format of the consult all that important. What I do find important is to define what is expected and relay which evaluations or treatments can be done and cannot be done. For example, psychiatry cannot do an evaluation for bipolar disorder if a patient is delirious, intubated, and nonverbal. The psychiatry consult team takes the team's observations and turns them into a consult question in the conversation to help set expectations. But in the consultant's mind, they must turn this question into a more broad subject in the theoretical sense, as to keep from having a narrow view in approaching the patient. Hopefully this broad subject can aid in the patient interaction. For example, if a primary team says this patient is acting weird, we might turn this into the question, does the patient's altered mental status have primary psychiatric etiology? But to do an appropriate assessment, it might be better to consider all the possible etiologies of altered mental status and consider which one might apply to this patient. Next, we go see the patient, call collateral, and do testing where appropriate. Eventually, we come up with a diagnosis and treatment plan. We call the team back and give them our recommendations. And the primary team determines if they want to take our recommendations. Now let's go back through this process and make sure we focus in on the liaison portions of the job. We can start with fielding the consult. There's a metamorphosis that occurs where the primary team has a problem in their mind, and that's converted into a question in the call. It's very easy to consider the primary team's observations or questions stupid as you gain more experience in the consult setting and the answers seem obvious. And the conversation over the phone can quickly become adversarial if 1, the primary team feels like the consultants don't understand or are trying to get out of work, or 2, the consultants think that the primary team is not getting it or trying to shunt work onto other teams. But the real problem occurs in communication and how the various specialties approach and use language to talk about certain things. Lastly, the rules that guide or confine each service, such as systems, limitations of diagnosis, like in the DSM, or protocols of the hospital or services, bed availability. These are all things that can cause contention between teams. When this infrastructure works, it's great, but when it fails, it can cause a lot of tension between the teams. So let's talk about how to avoid these pitfalls. It can be very helpful to remember that the whole premise of the consult is that the primary team really doesn't get it, and they're asking for help. At the same time, it's not their job to understand your specialty, nor your job to understand theirs. The team is calling for a reason. They need your help, and you should be kind of honored that they consider you valuable enough to utilize their time in getting you on board. Doing what's good for the patient. Sometimes everything about a consult is wrong, but always keep in mind that our primary concern is patient care. If you think that the primary team is really so off base that you want to refuse the consult, the patient probably could use a very understanding clinician like yourself in order to help be a liaison or advocate for the patient, if nothing else. Patient care is like a box of chocolates. You never know what you're going to get. Best to at least lay eyes on the patient and see what all the hullabaloo is about. Ultimately, rules were made to be broken because sometimes it's the right thing to do. The liaison role starts with the phone call. Now let's talk about what you can actually do, the nuts and bolts of fielding a consult. To understand the situation, you need to know what's going on with the patient right now and how that patient got there. Teams usually volunteer this information in their first sentence. But questions like, why was this patient admitted to your team and not psychiatry, can usually help get to the core pretty quickly if it's not offered up. How is this one different means getting to the primary team's perspective on the patient. As alluded to earlier, try and understand how this patient is different from all the other patients with the same diagnosis and treatment. Next, you want to figure out how this is affecting the hospital course or patient care. When something unusual happens, but it doesn't lead to a delay in treatment, discharge, or complaints by nursing staff, it usually doesn't become a consult. Lastly, you want to start the consult right away and set yourself up for success by setting expectations. If a team wants a non-sedating, fast-acting anxiolytic, just tell them right away, it doesn't exist. No need to wait until the consult is done to disappoint them, but come back with what you can offer. There may be no perfect medication for this patient right now, but maybe we can work with the patient to create some coping mechanisms to help manage that overwhelming anxiety that leads to hypoxia. Next, let's focus on the patient interaction and how this might differ from the standard psychiatric interview. In introducing yourself and the team, you can make a number of very strategic moves. If this person is naive to psychiatry or has some strong feelings about psychiatry, it might be most therapeutic to refer to yourself as a behavioral care specialist. I also like to get the patient's understanding of why this consult was called. There are often differing viewpoints as to the purpose of the consult. Lastly, I like to ask for permission, when appropriate, to engage the patient in a conversation. This gives the patient some sense of control and autonomy. My next goal is to answer the consult question. This can often be done more efficiently when there's transparency as to what you're doing and how these questions are connected. This also gives you an opportunity to get the patient's buy-in. You can reframe your consult question with a patient-centered perspective, such as, we're here to evaluate you for decisional capacity so that if in the case you're deemed to have capacity, you'll be free to leave the hospital as you've requested. So would you be willing to answer a few questions? Part of our job as psychiatrists is to screen for psychiatric etiology and safety. So to be thorough and make sure that we are not missing anything, I like to ask at least some sensitive questions in the three main categories of mood, psychosis, and anxiety, in addition to substance use in the social history. As consultants, we tend to see the zebras, so it's our job to make sure that we catch them all and none of them slip through the cracks. Lastly, we should always be thinking of how to liaison. In this role, we're able to be both saviors and sacrificial lambs, whatever the situation demands and that's in the best interest of the patient. Improving communication between the medical teams and the patient always improves outcomes. Now let's get back to the last component of the consult, making the recommendation. Notes. The primary purpose of a note is to relay information to the primary team. In the note, you can provide more details and illustrate your ideas more clearly and provide very specific instructions that are often more difficult to relay over the phone. Because the note is primarily for the primary team, it is important that it be concise, simple, and clear. This means leaving out uncommon acronyms and jargon. It is easiest to follow concrete and direct instructions. Talking around recommendations or using abstract language makes it more likely that mistakes will be made. A step-by-step approach is much appreciated. Don't say, gradually increase the dose. Instead say, day 1, 5 milligrams, day 2, 10 milligrams, day 3, 20 milligrams, etc. Keep in mind that nobody reads notes for fun, so best to keep what you find amusing or interesting to yourself. The callback. I tend to start out a callback with validation because it can reinforce good consults that you get and extend goodwill, saying things like, gosh, that patient is a handful. I can see why you consulted us. I'm glad you did. This can make all the difference in the world. The callback lets the primary team know that you did the consult and enables more timely relaying of information and recommended treatments. Lastly, this is your opportunity to discuss things that maybe shouldn't go in the chart, or to provide useful education in treating this patient that can often come across as demeaning, patronizing, or derogatory when it's in the note. Follow-up. Remember that the primary team has to write the orders because they ultimately are responsible and cover the patient overnight and hopefully know the patient the best and can put the whole picture together. You're not doing them any favors by putting in orders for them. Rather, you may be reinforcing their avoidance or stigma surrounding mental illness. It's important to see what the primary team chose to do, but don't get offended if they didn't follow your recommendations. It's not personal. Do ensure that they knew that you did put in recommendations. Maybe calling and asking why they were not followed might give you some more information so that you can be more helpful and on target in the future when similar consults come in again. Lastly, you want to see what your interventions did so that you can be your own quality control measure. Signing off should be a joint discussion. If you try and do so prematurely, you may just pay the consequences of being reconsulted. On the other hand, if you let every consult sit on your service forever, you'll never be able to provide the appropriate and useful care to your primary teams or their patients. Before you sign off, it's helpful to relay what you might do in the future in terms of tapering versus continuing medications and so forth. This can save you a call later down the road. Lastly, discussing the appropriate psychiatric follow-up is helpful and provides better continuity in patient care. So that's the consult process. I hope that this provides a better framework to enable efficient and effective consults in the future. Thanks.